We are at a moment of tremendous societal transition. Why on earth are there dozens and dozens of fax machines? They can flip a switch and obviously things get deployed overnight. That's not the US at all. The exciting stuff, the clinical AI, the assistant in my pocket that helps me remember to do the things that keep me healthy, that's coming. What happens when an AI tool fails? Who is responsible? Unfortunately, a lot of my colleagues have PTSD from sort of a bumpy deployment and rollout of electronic health records that was very frustrating. I don't think it's a failed promise. I think the journey has been bumpy and slow. A third of adults across the country have high blood pressure. What patient is going to accept the decision to have surgery for their colon based on an algorithm that I can't explain? We can do better. We should be doing better.
Hi, and welcome to our new episode of Digital Health Interviews. Couple reminders. First, please support Ukraine in any possible way. And second, subscribe to our channel. We would really appreciate it. Today we're in Milwaukee, and I'm incredibly happy to introduce you to our today's guest. His name is Dr. Jesse Ehrenfeld. Hi, Jesse.
How are you? Thanks for having me.
Thanks for doing this. Really excited about this episode.
Of course.
Let's start with your short background. Tell us some of your career journeys and also what are your main focuses right now?
Yeah, so I'm a physician here in Milwaukee, Wisconsin at the Medical College of Wisconsin. I see patients at Freighter Theta Care, and I'm the executive director of the Advancing a Healthier Wisconsin Endowment. So I moved here 6 years ago with my family. I was in Nashville, Tennessee, did my training in Boston. My background's anesthesiology and clinical informatics, digital health. So I've been doing work in the AI digital health development space for almost 20 years. I ran a research division before I took this current job today. Deeply engaged in the policy space, trying to understand how we can have regulations that support innovation and quality. And I spent a lot of time working at the American Medical Association. I was on their board for 11 years. And was president this past year. So have rotated out of my AMA responsibilities, but have a lot of interaction with regulators in Washington.
Very impressive. You've accomplished so much at your young age. How do you set the next bar? Like what's next? What you want to reach at this point of your career?
Yeah, I mean, for me, it's all about impact. I love being in the operating room. I was in the OR on Monday, taking care of patients. I had some brand new residents with me. It was July, so there's obviously a lot of excitement when we have new trainees coming into the profession, learning the specialty and all that sort of thing. And for me, that grounds everything I do. In fact, I had a patient who's a refugee from Ukraine in his 80s who needed surgery, who speaks no English, and it was an incredibly humbling, moving opportunity to help him and his family as he's trying to get established here in the States and obviously get his healthcare needs taken care of. But you take that and you zoom out and you think there are hundreds of millions of people globally who need better access to care. And I know through what I see in the policy lens, what I see here in Wisconsin, our work at the Advancing a Healthier Wisconsin Endowment, that if we don't have digital tools that can scale the capacity of our teams, then patients are going to continue to suffer lack of access here in Wisconsin and across the country.
I found one of your quotes, and you said that you can never stop practicing medicine because the patient connection is foundational. Wearing so many hats, is it still your favorite part of the job?
I tell people it's the easiest part of my job because I know what to do. Right. And on Monday, when I put on scrubs and I came to the hospital, clinical medicine changes and the practice environment evolves, but the physiology and the medicines and the drugs and the approaches are pretty stable. And so I know that I can make very discrete contributions. In my patient I was telling you about, left the hospital and is going to have a great outcome, and to be able to watch him leave with his family, knowing that I participated in that is incredibly rewarding. It's kind of immediate, and it's a very different place to work than what I do through our grant making at the Advancing Healthier Wisconsin Endowment, policy work at the federal level, or digital health development in the innovation community.
I wanted to follow up on something. You said that the knowledge in medicine is pretty stable, but still, like looking back when you were in college and you were studying, how much the whole concept of evidence-based medicine changed over these years?
So I think what's changing is there's still the desire that we practice evidence-based medicine, right, that every patient gets the care that we know is going to lead to the best outcome. But unfortunately today, we have a whole bunch of unreliable, disconnected systems that are siloed. And so for any routine process, acute care, chronic care, preventive care, all of the things that should happen, the prevention screenings, vaccinations, things that we know make an improvement in the process, all of those things happen only about 80% of the time. There's a huge gap between what we know is the best evidence and the best care pathways and what people actually get. And there are lots of reasons for that that are probably beyond the scope of this conversation. Where I think there's an opportunity is to use digital medicine and digital processes and AI and other tools to improve the reliability of our systems, right? So that because I'm tired or it's the middle of the night or somebody's unfamiliar, we have tools that can support us and augment our capabilities to ensure that every patient gets all the things that they need when they need it.
Very interesting. All right, so those were my hardest questions. All these just one left. Here's an easy one. So the US is one of the wealthiest countries in the world, and yet hundreds of thousands of people go bankrupt due to medical debt.
Sure.
If you would write a prescription for the US healthcare system, what would be on it?
So expand access through the use of digital tools, telemedicine. We need to reform our payment structures. Unfortunately, how we pay clinicians and physicians is very outdated. It hasn't kept up in ways that is causing all sorts of conflicts in the marketplace. There are things that we know could modernize the Medicare system, could modernize third-party payer systems, that could improve access writ large. And we've got to invest in prevention. Unfortunately, we have a sick care system. If you're sick, you can get the best care. The problem is we don't invest in the prevention that can prevent people from getting sick. A third of adults across the country have high blood pressure. A third. Only half of those patients have blood pressure that's controlled. That's an incredible opportunity to reduce preventable strokes, preventable heart attacks, preventable problems that we know are going to happen because we have millions and millions of Americans who have high blood pressure, but you don't need a fancy new injectable peptide that costs thousands of dollars a month to treat high blood pressure. The pills are basically free. It's these systems problems that we know we can lean into with digital health approaches, remote patient monitoring, care teams that are working asynchronously to get people engaged in their care that can have such an important difference. And we're working on a lot of those things here at the Medical College of Wisconsin through our funding led by the Advancing Healthier Wisconsin Endowment.
You've mentioned a really important point about prevention. And lots of times when I talk to physicians about value-based care and like this switch from fee-for-service model to value-based care, all doctors very upset with me because every doctor thinks that there's value in all the work they do, obviously. But if we kind of go abstract on the national level, do you think value-based care is a failed promise or we're going to get there?
I don't think it's a failed promise. I think the journey has been bumpy and slow. And unfortunately, the payment incentives haven't really materialized to move us in the direction of having value-based care. I think that there are some things that the administration is very interested in doing to try to lower the barriers to bringing on value-based care contracting. I think there are things that are happening around data interoperability that can support value-based care work that's really important. Unfortunately, a lot of what needs to happen to unlock value-based care models is better access to data to support risk sharing and understanding of who's accountable in these sort of value-based care arrangements and contracts. And there was a big announcement this week at the White House with the CMS Administrator, Dr. Oz, and the President himself around things that they're trying to do to incentivize private industry, third-party payers, technology companies to make these pathways easier. we'll see what actually happens, because all these things are actually voluntary agreements that they're trying to get companies to sign on to.
Kind of my personal observation, it's much easier to implement value-based care in a smaller practices. And once you get like to a large health system with huge budget, for them, it seems very unrealistic at this moment to implement it, because everything is based on fee-for-service.
You know, the challenges are actually quite different. So when you have a large organization, a big system, there are enough patients that you can share risk across patients, right? So the financial opportunities are actually smoother for large organizations, but I agree the operational challenges of changing care pathways are sometimes more difficult in larger organizations. So I think that there are different challenges depending on the size of the entity that's trying to move in that direction, but they're not unique.
How would you define health equity? And if we're talking about success in this space, what would be like a practical example in the clinical setting?
I mean, health equity is pretty simple. It's everybody has access to the same best possible health outcomes at a patient level, regardless of who you are, where you live, what you look like, who you love, where you were born. And unfortunately, that's not happening. It's not happening here in Milwaukee, Wisconsin. It's not happening across the state of Wisconsin, where our rural communities suffer disproportionately poor health outcomes because of access problems, geography. It happens across nationwide. We can do better. We should be doing better. And there are a number of things that we know we need to do to smooth the pathway to reducing those disparities based on who you are, where you live, what you look like, that obviously could make a big impact. And we're very focused as an organization here at the Medical College of Wisconsin in trying to lead models to improve health equity and access and those kinds of things. A lot of it has to do with workforce, making sure that we can ensure that everybody has access to healthcare insurance products. Obviously, there's a lot happening with the Medicaid program right now at a federal level that's creating some uncertainty about what that is going to look like in the future. But regardless of what those mechanisms are, I think there is a pathway to improve things.
Fingers crossed. Let's get closer to tech, which is an important part of our channel.
Yeah.
At your opening speech as a newly elected president of American Medical Association, you mentioned that AI is going to transform healthcare. And I assume you're not talking about AI scribe tools or like back office work optimization. What did you mean by that?
So we are at a moment of tremendous societal transition. And I think people know we're in this AI era. But I don't think people realize that the next 20 years, we're going to come out on the back end and society is going to look very different. I can't predict what that means, but I think we just have to understand that there will be seismic shifts that have happened at other points in society, the Industrial Revolution, where organization, system, civilization just looks different. And I think that we're only starting to enter into this space. Obviously, healthcare is an important component of that. You talk about, where is AI today? I mean, almost a majority of practices, if you look at national data, are using AI tools. Now, a lot of it's back-end office, sort of low-level things, scheduling, supply chain, finance, ambient dictation. Those things are interesting, and I think they're fine, and I think they do help with an operational standpoint. The exciting stuff, the clinical AI, the assistant in my pocket that helps me remember to do the things that keep me healthy, that's coming. And that's coming quickly. And I think those tools are the things that are going to reduce the barriers to access and enable people to actually unlock their best possible outcomes to improve health. But the clinical AI applications are actually having some uptake, but that uptake is slow. Now, there are some areas where adoption is just exploding. So radiology, image interpretation, the tools that allow immediate, always-on interpretation of a CT scan or any other image. Many hospitals, thousands of US hospitals actually have brought those tools online, and they're changing pathways. I could give you lots of examples of what that actually looks like on the ground. But the pathway to clinical AI adoption is also one that has many challenges. And unfortunately, we have a situation now where no CIO, no CMIO wants to incorporate 47 different tools from 30 different vendors, and it's $5 million each to do the testing and the deployment and the validation, the ongoing monitoring. Nobody has the capital to invest to actually do that at scale. So a lot of systems have picked things that they provide the most value, or they're doing pilot testing on a handful of tools. But what we need to move to is a system of going from point solutions to platforms. Now, obviously, there's tension in the marketplace around, who's going to own the platform and what's the platform going to be. The EHR vendors, of course, would love to be the platform. There are other organizations and entities that would also like to be the platform. I don't have any opinion about what the most effective way is going to be. But until that gets resolved in the marketplace, I think we're going to be challenged in terms of the actual implementation of these tools, and it will be slow.
I'm 100% with you on this. I think last probably 20 years we're digitizing healthcare, basically paper record to electronic record, fax to telehealth and other things, which is still not fully completed. Yeah. But I think AI should actually transform, not just digitize healthcare. So
yeah, you mentioned the fax machine, and I have a very funny story. When I was deployed in Afghanistan in 2014, 2015, there were a few moments where things were slower at the hospital and we didn't have so many casualties, and so I would help out doing various miscellaneous tasks, as a good officer does. And there was a day when we were trying to offload excess equipment that we had at the facility, and so I rode with some of my corpsmen to the dump, and we unloaded this truck, and the truck was filled with fax machines, brand new fax machines. And I said, why on earth are there dozens and dozens of fax machines, brand new in the box, that were shipped here, from back home? And the answer I got was, well, you're a hospital. Of course you need fax machines.
Yeah, so that sounds obvious, right, to lots of people?
Right.
I want to read the stats and hear your opinion about this. So Chinese clinicians lead AI adoption at 71%, while US adoption lags at 36%. What cultural, systematic, or regulatory factors do you think influence that disparity?
Yeah, I'm not familiar with that particular statistic, but it doesn't surprise me. China has a centralized control of their systems and their government, so they can flip a switch and obviously things get deployed overnight. That's not the US at all. The Chinese government also has a very different way of dealing with liability issues. Obviously we have liability concerns, and those haven't been quite sorted out in the US marketplace when it comes to what happens when an AI tool fails. Who is responsible? Who is on the hook? And should that be the clinician, the end user who used the tool in a care process? What if it was the model that was poorly developed, or a deployment problem with how the model was implemented by the health system? Until we get some of those liability considerations sorted out, I think there is going to be a little bit of uneasiness with the use of these tools. The other issue that we have is, we incentivize through your taxpayer dollars, my taxpayer dollars, the adoption of electronic health records through federal incentive programs by the US government. And that was not a bad goal, but the technology was not primed to do it. And unfortunately, a lot of my colleagues have PTSD from sort of a bumpy deployment and rollout of electronic health records that was very frustrating. And people, they know these tools can make things better. They want these tools to make things better, but they also want to make sure that they're not sold a bunch of snake oil that makes their jobs worse in an environment where people are stressed and burn out, and there's a lot to do to get through your day. And so people want tools that are an asset, not a burden, and unfortunately the experience of EHR rollouts was anything but that.
I want to double click on what you said about liability. Like, as of now, still 100% of liability is on doctors. Like, engineers have really zero liability at the moment. I wanted to ask your opinion on AI scribe tools that actually did not pass any regulation so far, but they have been adopted all over the place now. Is that a good thing or a bad thing?
Well, I mean, the ambient dictation tools I think are helpful, but it's very clear that they're an assistive technology, and it's my responsibility to review, finalize, and sign the note. Right. So I don't think anybody's fooling themselves into thinking that the ambient technology is completely autonomous in generating billing documentation on its own without human in the loop review. Now that's a very different scenario where you have tools where there's not a human in the loop, or potentially could. And there, I think those questions of reliability are just very, very different. The regulatory scrutiny probably needs to be different. And ultimately, it comes down to a risk framework, right? And I think there's clarity in other industries around the level of autonomy, automation, and risk. You look at the National Highway Transportation Association's view of that, administration's view of that, or others that are out there in the world. We don't have consensus on what that should look like in healthcare, but I think it obviously parallels pretty nicely.
There's a lot of hype right now in the clinical decision support tools with using AI. Have you tried any of the solutions? What's your take on that?
Yeah, I mean, we have a lot in the pipeline here at Freighter Theta Care. I'm not as familiar with Children's Wisconsin, our other clinical affiliate, because I don't see patients there. But dozens of things are in various stages of evaluation, deployment, testing, going live. So I think there's a lot of excitement and there's definitely value in these things. The challenge is, again, if we've got dozens and dozens of tools from different vendors, point solutions, the runway to actually get these things into practice is quite long. At least for the AI tools, we have probably thousands of clinical decision support rules running in various ways attached to our electronic health records or other systems that I think is pretty standard for most facilities. But I think we're talking about something very different than that traditional kind of CDS.
In many of your interviews, you talked about physicians' burnout,
Yeah.
which is a huge problem, especially considering the lack of healthcare professionals in this country and across the world. Can AI be any of help to reducing that burnout?
I think it can, and AI is not going to, I think, replace people, but I think it's going to upgrade us. It's going to make us more effective. I think it's going to make our jobs easier. And there's a lot of busy work that goes with being a physician or another healthcare professional that these AI tools can make easier. Ambient dictation is one of them. I don't think that the ROI on ambient dictation is about seeing more patients. In fact, the studies, I think, are pretty clear that maybe you see one extra patient a day, but in a primary care clinic, that doesn't actually in any way underwrite the cost of what people have to pay for these tools until the prices start to come down. But the satisfaction of not having to sit at home in your pajamas at night finishing your notes is obviously an investment that a lot of systems think is worthwhile to reduce burnout, exhaustion, and make people's lives better. So I think that's an example of where these AI tools can be really, really helpful. But again, it comes down to making sure that the tool matches the workflow and doesn't make it harder for me to get through my day.
So if I understand correctly, the main incentive for health systems right now to adopt AI scribe tools is to decrease burnout.
Absolutely.
Well, I hope everybody understands that. All right, so I want to ask your opinion about new administration. I feel like they're still trying to figure out which direction to take. Are you feeling optimistic, frightened, or is it still too soon to say what's going to happen?
Yeah, I'm very optimistic. I think there's a lot of exciting things that are coming out of the White House and HHS that are very much aligned with sort of what we're trying to do to improve health, improve access, ensure that the innovation that we know is possible can actually occur. And so we'll see how those things obviously come together. It's still early days of the administration. There's been a lot to try to keep track of. It's not all positive, but I think there's a lot that is positive, and obviously we're trying to figure out how we can align with the things that do make sense for us to do as an organization here with what we do at MCW.
Some argue that the U.S. healthcare doesn't have a cost problem, it has a price problem. Would you agree with that? And if so, what can be realistically done to improve this?
So I'm not an economist, so the difference between cost and price is probably not something that I could speak to. But certainly there are places in the market where we have opacity around what's happening with how things are priced, charged, reimbursed, that makes no sense and is driving up prices for consumers. The PBM space is an obvious example of that. That's been a target of the administration of Congress as of late, and I think there will be movement to try to ensure that dollars are actually going to things that provide value and not just being sucked out of the system to support corporate profits.
I like this example of cost plus drugs company that bring actual transparency to the pricing. Do you think something similar can be implemented on the health system level?
I think there's opportunity there. There have been efforts around price transparency, but I, as a consumer, I have tried to use those tools and ask for price estimates. They're still hard to get and they're not meaningful, right? So it's still not like you can go online and look at the difference between the price of something at Walmart or Costco and then make a decision as a consumer. People are still pretty locked into where they live, where they have access, and even if they are planning to shop around for some elective, expensive procedure or drug, it's not easy to do. So given where we are with technology and data and AI, I can't imagine that there won't be more attempts from this administration and others to make that easier, but it's definitely a problem that we haven't solved.
If we zoom out 20 years from now, what kind of legacy would you like to have in healthcare?
For me, I really am driven by a desire to leave things better than I found them. as a physician, as an informaticist, as a dad, I want to make sure that there's an opportunity to, when all is said and done, and I'm hopefully sitting somewhere enjoying time with my family in retirement, I can look back and know that things got better because of the projects and the programs and the research and the things that I was engaged in. And better for me means better access, better outcomes, less cost, and ensuring that people get what they need.
Our main target audience are startup founders in digital health. We usually ask our guests in the end to give some sort of recommendation or piece of advice to startup founders, especially early stage. What do you think can make their life easier, or they can actually skip some mistakes that some startup founders do? What would you recommend them?
What I would say is there is tremendous opportunity, and I have run into so many situations where everything has gone wrong. And it's easy to be frustrated, it's easy to throw your hands up in the air, and sometimes the best thing you can do is put something aside, take a walk, go for a long drive and come back to it the next day or the next week. And for me, having a very broad portfolio of different things that I'm engaged in, different companies that I work with, different programs that we're running here, allows that to happen. I had a really frustrating day yesterday, and when I got home last night, it all got put aside, and it's all, we'll revisit it on Monday. And I think that we all have those moments in different aspects of our life. It's important to recognize that, create that space, because sometimes a recalibration or an opportunity to just reevaluate a problem on a different day is what it takes to unlock a solution or a different pathway.
That's important. The last thing I was going to ask you to say is why, for startup founders, it's crucial to bring a physician on board, like from day one.
So I will tell you a funny story. I was at a conference at a big healthtech meeting, gave a keynote, and an entrepreneur came up to me afterwards, and he was like, "Doctor, I've got this great algorithm, and it can tell us when we have to take somebody's colon out because of colon cancer." And I said, "Okay, that sounds interesting. Like, how does it work?" "Well, it's a black box model. I can't exactly tell you. It's not really explainable, but it makes the decision, do you need to operate or not?" I said, "Okay, time out. What patient is going to accept the decision to have surgery for their colon based on an algorithm that I can't explain? What third-party payer is going to reimburse the physician for making that decision without some evidence behind it?" So it was obvious that disconnect between somebody who was doing some data modeling work, had this idea, understands that there is a problem to be solved, but had no awareness of the clinical reality around how these tools would be used, accepted, or reimbursed for. So I'm a big advocate and proponent of having the voice of physicians and clinicians at the table throughout the design, development, and deployment stage of important technologies that we're going to be expected to use, because you get better products. And we've all seen technology that has promised things, but it hasn't lived up to it, and that's a way to solve that.
Couldn't agree more. Thank you so much, Jesse.
Oh, it's my pleasure. Thanks for coming up.